Hi guys, welcome back to week 10. This week our focus is on musculoskeletal. This week's readings were focused around spinal disorders, soft tissue disorders, osteoarthritis, and osteoporosis, as well as musculoskeletal guidelines in terms of differentiating plantar fasciitis, sciatica, sprains, those kinds of guidelines. And then we also got into musculoskeletal procedures, including diagnostic testing and procedures. So in the lecture today, I'm going to focus on the musculoskeletal disorders, injuries, how to approach them, definitely a focused physical assessment of the musculoskeletal system, including diagnostics that you would want to include and blood work that's really incorporated into orthopedics. Imaging and indications of and diagnostics we're going to get into, and of course we're going to focus on the common musculoskeletal complaints. We're going to talk about occupational health, differentiate a couple of things, including like sciatica, hip pain and fracture, shoulder and elbow pain, focused assessments for hand and wrist injuries, as well as neck injuries. And then, of course, how we apply all this to practice. The one thing I'll just say is we're not going to get so much into X-ray and radiology interpretation. We really just kind of encourage you to try to review that on your own. That's something you're really going to get in practice. There are a few basic questions on the boards about radiology. Those particular things we will, kind of go over and make sure you know the basics. But in terms of really interpreting and reading those kinds of diagnostic X-rays and stuff, that really comes into practice with practice. All right, so let's get started. So again, additional information, resources that we wanted to make sure to point out to you, bonetalks.com and radiopaedia.org. These are just different places and resources to help review X-rays and imaging, and just give you a lot of visual imaging in terms of how to interpret and assess orthopedic injuries. So of course, radiology and interpretation of these diagnostics takes a lot of practice. So this is why we want you to focus on just knowing the basics and then knowing what to look for in the radiology reports or X-rays, imaging, and what your landmarks are that will help you systematically approach those kinds of interpreting of results. Okay. Next, I wanted to do the musculoskeletal overview, a quick video just to do a nice review in terms of, just knowing the basics and reviewing the basics. So here's a quick 5-6 minute video just to give you a good animated review.
The muscular system is made up of over 600 muscles. While we won't be covering all 600 individual muscles in this overview video, we will be discussing the main functions of the muscular system, the 5 major properties, the 5 types of muscle movements, 3 types of muscles, and how all of this works together to make up what we know as the muscular system. The primary purpose for the muscular system is to provide movement for the body. Now, these muscles receive their ability to move through the nervous system. There are 5 major properties to the muscular system. Number 1, muscles are excitable or irritable. This means that they are capable of receiving stimulation and responding to stimulation from the nerves. 2, they are contractible. After receiving stimulation, they are capable of contracting or shortening. Being extensible means a muscle can be stretched without damage by the application of force. With elasticity, a muscle is able to return to its original resting shape and length after being extended or contracted. The muscular system is adaptable in that it can be changed in response to how it is used. For example, a muscle will enlarge or undergo hypertrophy with increased work. But on the other hand, it can go into atrophy or waste away if deprived of work. Now, let's look at the 5 types of muscle movements. Number 1, adduction. Adduction is the moving of a body part toward the midline of the body. Abduction is moving a body part away from the body. Flexion means bending a joint to decrease the angle between two bones or two body parts. Extension is straightening and extending of the joint to increase the angle between two bones or body parts. And lastly, rotation involves moving a body part around an axis. The muscular system is divided into three main types of muscles, and each of these types can be moved by one of two ways, either voluntary or involuntary. The cardiac muscle is an involuntary muscle, meaning it operates without any conscious control. These muscles form the walls of the heart and contracts to circulate the blood. The visceral or smooth muscles are also considered involuntary. These muscles are found in organs or organ systems such as the digestive or respiratory system. And the third type of muscle is the skeletal muscle. These are what we typically think of when talking about muscles. These muscles attach to the skeleton and provide the skeleton with the ability to move. The skeletal muscles are classified as voluntary. This is because we have to make a conscious effort or decision to make them move. Although muscles obviously make up the muscle system, there are still some supportive structures we need to look at that are also a necessary part of the system. Tendons and fascia are important supportive structures for the skeletal muscles. Simply put, tendons are what attach a muscle to a bone, and fascia connects muscles to other muscles. Tendons and fascia work together with muscles, which create the muscular system necessary for movement. While not technically part of the same system, the nervous system is intrinsically connected to the muscular system of the body. It is essential to the voluntary skeletal muscles. If the communication from the nervous system is severed from the skeletal muscles will not be able to produce movement for the body. The body is now in a state of paralysis. This is known as quadriplegia. The only organ that is not directly dependent upon the nervous system is the cardiac or heart muscle. Now there is so much more to discuss about the muscular system, but that's as far as we'll go in this introductory video. After watching this video, you should at least have a basic understanding of what makes up the muscular system, its properties, and functions. For a more in-depth study of the muscular system, look for future CTE videos where we will cover topics such as the 14 major muscle groups, as well as topics such as common diseases and conditions specific to the muscular system.
Yeah, this is a great video series by CTE that you guys, I would definitely encourage you to check out if you wanted more review. Just a great visual explanation in short bursts of time, which are always very helpful in my world for learning and just retaining knowledge. Okay, so approaches in musculoskeletal disorders or injury. So you always want to get a thorough history with these particular patients, really find out what happened, what's going on in their lives, any recent falls, any recent injuries. So in this particular assessment, we're questioning, is this condition acute or chronic in duration? Did it just happen recently, or has this been going on a long time, and how long? Articular joint or non-articular joint in origin. Is it inflammatory or non-inflammatory in nature? Do we see swelling or no swelling? Is it localized or systemic in distribution? The exam, in terms of the exam, we want to recommend that it includes examining the non-affected side first, when applicable or where applicable, and then move to the exam of the affected side and make the comparison. So again, you want to examine the side that's not injured first, and then look at the side that is injured or the affected side, so that you can really get a comparison of what their normal is versus what is now abnormal according to the patient. So your focus on your history, in particular to musculoskeletal problems, these are the questions you want to ask your patient or caregiver. Has the patient injured themselves? Have they had a fall? Did they have a recent car accident? Any kind of random injury that recently happened that they may not even think is a big deal, but might have possibly perpetuated this particular injury. Describe exactly how the injury occurred, when it occurred. Did it make a noise or a sound? If so, describe the sound. Breaks, fractures. We want to know popping, cracking. Does the patient experience any crepitus when the joint is moved? Where does it hurt? Does the pain radiate or is it localized? Numbness or tingling? Is there a loss of function or a decrease in function? Is there swelling? When did the pain first occur? What relieves it? What makes it worse? What time of day does it occur? Does the pain awaken the patient at night? How bad is it? How much pain medicine are they requiring to manage and still be able to perform their normal functioning activities of daily life? How often are they taking that Tylenol or Motrin? Do they have any other symptoms systemically you want to think about? Do they have a fever, a rash, general fatigue? Have they recently been traveling or camping? Any bug bites, any tick bites? Have you recently been immunized? Have they recently been treated with any antibiotics? Do they have any history of upper respiratory infection, STDs, chronic diseases? Have they ever been treated with steroids? Do they have any allergies to steroids? And definitely get an idea of what their daily activities include, including their work, hobbies, their home life, their amount of stairs in their home, that sort of thing, because all of that will dictate, how the patient is going to proceed going forward in their care and in your need to follow up with them. Also, if you needed to provide them with a letter in terms of work, obviously, if they're very physical at work, and they suddenly have an injury, they may need a note to excuse them until their injury is relieved. Okay, physical exam in musculoskeletal disorders. So one of the, this is the advanced assessment, basic stuff. You're looking, what do you see visually? Do you see any swelling, bruising, redness, erythema, any lesions, previous scars from surgery, any visible deformities? If you see any of this, of course, you're documenting it. You want to palpate the affected joint above and below, assess for crepitus. It's that cracking of the joint, which can suggest a joint or articular injury. You want to check if there's any joint effusion present. Is the patient point tender to palpation of the joint or the soft tissues? You want to assess the range of motion, ROM, assess both active and passive, note limitations and discrepancy. Remember, in terms of your strength examination, it's 0 out of 5. Okay, 0 being no muscle twitching or movement, also known as a paralyzed limb, versus 5, which is full strength of their extremity. 4 out of 5 would be weakness of extremity, but still can move against gravity. 1 out of 5 would be muscle twitching with no movement. So make sure you're aware of these numbers because this is a standardized strength exam number that you'll be documenting with. So you'll also know how to read it when another practitioner documents the same thing. So you're looking at joint stability, special tests. In terms of joint stability, you would be doing stress testing or joint play. Special tests would include the shoulder empty can test, which examines the rotator cuff. The knee McMurray test, which looks at the meniscus. The Lachman test, which looks at your anterior cruciate ligament. And then, of course, your Sperling's test to check for radiculopathy. We're looking at our lumbar spine with a straight leg and reverse straight leg raise to assess for herniated discs. We're doing the Thompson test to assess for Achilles rupture. It is your responsibility to be conscious of how these tests are performed. So I would encourage you to go ahead and either look up pictures of how this is performed. Your Coiler book definitely has that. What was it, your Coiler book? Let me just look at that again. Yeah, it's the Coiler book has these particular things. Your cash book might also, but YouTube is a great resource for just watching mini videos to just get a quick review on how these tests are done. Those you learned in your undergrad in health assessment, so hopefully it'll just be a review for you. Of course, you're doing a neurovascular assessment examination, and you want to perform extremity reflex testing at the following locations to check for specific spinal nerve injury. So L4, S1, C5 to C6, and C7 in your triceps. Okay, diagnostics. So common blood work associated with orthomusculoskeletal is your CBC, your ESR, your CRP, RF for rheumatoid, ANA is for lupus or systemic lupus, Lyme testing, uric acid, and gout. All right, sometimes labs can be misleading, especially in early rheumatoid. So if the lab work is normal, evaluate the entire picture. And if in your CBC, does the patient have anemia? It may be a clue to the inflammation or white blood cells for infection. Are our ESR and CRP values elevated? Because remember, they are non-specific indicators of inflammation. So highly increased values suggest inflammatory rheumatic disease, infection, or malignancy. That number also increases with age. 5 to 10% of the population have increased values with no explanation, and up to 40% of patients who present with RA have normal ESRs and CRPs. So don't always rely on these blood work values. In patients with giant cell arteriolitis and polymyalgia rheumatica, the ESR is almost always markedly elevated. Therefore, the diagnostics actually are useful in these particular differentials, giant cell arteriolitis and polymyalgia rheumatica. But again, just a quick, so just so we are clear, the common diagnostics that you would want to order if you were concerned about any orthopedic or musculoskeletal issue would be your CBC, your ESR, your CRP, and your ANA, and uric acid and Lyme testing, okay? All right, so diagnostics. So your rheumatoid factor, 25% of patients with RA never have an elevated rheumatoid factor. This value may also be elevated with other inflammatory conditions, including SLE, subacute bacterial endocarditis, vasculitis, and a viral infection. So you're going to do a fluorescent anti-nuclear antibody test or an ANA. In 99% of patients, it's positive with systemic lupus. All right, it's not a highly specific so not highly specific, and positive ANA titers can occur with severe infection, certain drugs, and other inflammatory conditions. So your Lyme's disease is identified serologically by antibodies to the Lyme Borrelia organism. And then you want to check uric acid to rule out gout because it's high, elevated levels in 90% of patients with gout. So that's pretty accurate in terms of its diagnostic. Screening panels, various panels or groups of tests to screen for inflammatory conditions, high false positives, not highly recommended. You can order the labs singularly. Remember, these are also expensive to order. It's not, free. Every little thing you add on is definitely charged to the insurance. So you want to make sure the patient's insurance can cover it, as well as it's really appropriate for the patient. If you're finding that you have to go to this level of screening and diagnostics, that's when you want to consider consulting with either rheumatology or an orthopedic specialist. Okay, so when is imaging indicated? When your physical exam cannot localize which structure is actually causing the symptoms, it's definitely indicated after any kind of significant trauma or car accidents, with the loss of joint function, like they're suddenly unable to bear weight, when the patient's pain continues despite conservative management, when there's a fracture or a bone infection is suspected, and when there's any history of malignancy in the patient's family. If you're unfamiliar with what views to order, you just want to contact your radiologist for guidance, or just ask a fellow NP. There's only a few ways to order it. So in practice, here's some just key pearls for imaging when it comes to ordering x-rays. They have a very low threshold, meaning be more inclined to x-ray. Okay, so the elderly, the older adults with aging, they have a tendency to easily fracture, especially with a lot of history of osteoporosis. People with comorbidities like in diabetics, infections and fractures of soft tissue injury make healing very difficult. So you want to take that into consideration. Cancer, active cancer or history of cancer, definitely you want to consider x-rays because they may have metastatic or bone cancer. So if we have a disproportionate response in pain or presentation to the injury, or the mechanism of injury doesn't seem to match the presentation, you want to consider abuse, because a patient may tell a different story that doesn't match what you actually see on the x-ray, especially if the x-ray is showing a severe thing that really doesn't match up to the story the patient is telling you. Why? Why do these patients all have a low threshold? Because these patients are more likely to fracture. They have a increased joint space, bony and soft tissue infections, and other conditions that can present throughout, with their comorbidities. So X-rays detect erosions, calcifications and cysts, osteopenia, narrowing of joint spaces, deformity of bones, and separations, including fractures and dislocations. Not so helpful with low back pain. It's a soft tissue injury, but likely to rule out other causes in low back pain because there might be underlying arthritis. We may not always pick up arthritis, but X-rays are still done as the first line of imaging prior to MRIs many times, just because it's more readily available, patient can tolerate it better, it's cheaper, that's why usually. In practice, here's some pearls in terms of orthopedic evaluation. Differentials you always want to consider include trauma, infection, metabolic or circulatory disorders, tumors, synovial conditions, congenital or developmental problems, or degenerative disorder related diagnoses. Be very familiar with 2 to 3 NSAIDs and other common pain medications because you want to have those in your back pocket when it comes to prescribing. You also want to make sure you're very clear about documenting and understanding the mechanism of injury, quote unquote. It's very important. It's used in practice. This is just referring to how did the injury occur? Like your documentation is going to say mechanism of injury as reported by patient, blah, blah, blah. It's often as clues as to what the injury is, especially in fractures. You definitely want to document if there's any visible deformity, assess for and document the presence or absence of a visible deformity, often a pertinent negative when working with musculoskeletal injuries. So remember these pertinent negatives, we've talked about this before in terms of documentation. You want to make sure you're documenting the presence or absence. You want to make sure you're stating, I don't see there's no visible deformity on assessment, or there is a visible deformity and describe it as such. You want to use proper medical terminology for bones, joints, the surface of the body, example, volar, dorsal, in terms of describing the location, just to be very clear about where and what you're looking at. In practice, more pearls. Okay, so the FNP can get additional training in performing injections, splinting and casting, depending on where you work. Obviously, in a clinical setting, you're going to probably have, especially if you work in any kind of orthopedic office where they do trigger point injections, which are very common, especially for pain management. You'll get a lot of practice with that. Splinting and casting, of course, depends on the setting. They are applied for immobilizations, usually done in an orthopedics office or in the emergency room. It's more safely done usually with air casts and non-plaster permanent materials until the patient gets to orthopedics. Nerve blocks to treat pain, anesthesia, and areas for suturing, that's more you're definitely going to see while in practice. So in extremity injuries, things you want to watch for are nail bed injuries because they often clue you in on whether or not the patient needs an X-ray. If there's any underlying tough fractures or embedded materials like glass or gravel, those are all clues. Definitely you want to make sure you cover the patient for tetanus. If there's any break of skin, you want to provide coverage in terms of your vaccinations. You don't want to just send the patient out of the office with crutches. They need instructions on crutch walking and document that was provided because there's a lot of falls associated with crutches. So patients really need to be educated on how to use them appropriately and make sure they're measured appropriately for the patient's height. Anytime you splint or impair a normal function of any extremity, even on an arm, the patients are especially at higher risk for falls, especially the elderly. So remember, anytime you throw off a gait, whether it's upper or lower extremities, you are causing a change in the patient's balance, proprioception, and gait. So you want to be very clear on educating the patient on fall prevention and the use of the splint. Patient education should also include avoiding excessive use of the splint to prevent a frozen shoulder. And of course, if you are splinting the injury, you definitely want to consult with physical therapy and refer the patient as indicated, whether it's to orthopedics, physical therapy, or occupational therapy. And you want to also consider, can the patient be safely at home with this new musculoskeletal injury? Do they need assistance or rehab? These questions could take potentially a lot more of your time, but you need to make sure you address this for the patient's safety. Things as simple as setting the patient up with home care services where they have a visiting nurse, a physical therapist, and a home health aide come out to work with them could really benefit this patient and prevent any kind of further injuries. Other imaging studies you want to also include are an ultrasonography, which will look at soft tissue abnormalities. It's helpful in the diagnosis of Baker cysts and other superficial prominent lesions, such as lipomas. You want to consider CTs to visualize the axial plane. It's useful in low back pain syndromes like herniated discs, spinal stenosis, spinal trauma, and advanced osteonecrosis. You want to consider MRIs with soft tissue disorders, example, muscle tendon tears and intra-articular disorders like meniscus tears, as well as spine disorders. They're very commonly used to test. MRIs are often reserved for patients who fail conservative management of soft tissue diseases after about 6 weeks. You want to see specifics for each disease, consider if the patient can actually tolerate the MRI, the presentation of the injury, etc., before you actually prescribe this diagnostic, as well as making sure their insurance will cover it. Other imaging to consider as well are bone scans, nerve conduction studies, and joint aspirates. Bone scans are not ordered routinely in family practice. Again, some of these imaging, it's more important for you to know what they are so that you know what they're looking for in terms of diagnostics. But the reality is the likelihood is you won't actually be ordering these particular diagnostics. They will be done by the specialists. Okay, spasms, strains, and sprains. So spasms are persistent, painful, and reversible contracture of striated muscle versus strains are muscle injury caused by excessive stress placed on the muscle that results in stiffness and decreased function versus sprain, which is a stretching or tearing of the ligaments that occurs when a joint is forced beyond its normal anatomical range. We have first degree sprain, which is a stretching of ligament fibers. We have second degree sprain, where we have a tear of part of the ligament with pain and swelling. And then we have third degree sprain, which is a complete tear with a complete opening of the joint on stress. So that's where you would immobilize and possibly need a repair. So remember, in terms of spasms, strains, and sprains, we are grading them in grade 1, 2, and 3, 3 being the worst. Okay, so the old school mnemonic price and other principles of treatment for musculoskeletal issues. In terms of the acronym PRICE, we want to protect, rest, ice, compression, and elevate. We want to reassure the patient that the injury will hopefully resolve in the near future. It just takes time. You want to make sure you're educating them to limit their activity. It's reasonable to immobilize the area during the diagnostic phase just to prevent any further injury. The NSAID is the first line and for most musculoskeletal injuries. It may require other meds. You just want to watch and see what works for the patient. You want to make sure you're looking at side effects in terms of GI or cardiovascular side effects. And of course, you want to consider if they need higher levels of pain management to prevent them from being able to work on their therapy and complete their therapy. Obviously, we want to refer to orthopedics if it's not resolved and consider imaging if it continues to worsen. So common complaints that you're going to see usually are acute musculoskeletal injuries, which is less than 6 weeks in duration, which mostly are spasms, strains, and sprains. You're going to see muscle cramps, which are sudden involuntary that can last from seconds to several minutes. You're going to see myofascial pain, which is caused by the development of trigger points within a muscle, not visible on X-ray. It's disabling. It's seen with fibromyalgia. It's also seen with what's the one of the face? Not fibromyalgia. I'll think of it in just a minute. The other ones we want to consider are paresthesias, sensation of numbness, prickling, or tingling experience in central and peripheral nerve lesions. A lot of the times that's caused by anatomical or mechanical nerve injury. This myofascial pain also refers to the trigeminal neuralgia. That's what I was thinking of. These both actually refer to that kind of pain. Excuse me. So we have different types of pain, and each type of pain presents a little bit differently for different reasons. So just consider the different ones. So in terms of neck pain, you'll usually see numbness, tingling, radiation, and it's usually localized. The red flags that you need to be very conscious of when it comes to neck pain are fever, loss of function, erythema, and systemic symptoms. Okay. We always consider the neck concerning because remember your respiratory area is right there. So if we start to develop swelling or loss of function, we're in trouble. Back pain, things that we would include in causes of back pain would include lumbar strain and sprains, nerve impingement, nerve compression, radiculopathy, and fractures. Shoulder pain is usually from the neck, chest, or diaphragm region. It's most commonly caused by a local process. Elbow pain is usually most associated with tennis elbow. Wrist and hand pain is usually diagnosed with the Allen's test, the Phalen's maneuver, and Tinel sign. So remember to be familiar with those. Hip pain in and around the hip can often be felt in the groin or buttock and can also be referred to the thigh or the knee. All right. And then of course we have knee pain and foot pain. Paresthesias, common causes, which are often overlooked. So always consider this in your differentials. We have the brachial plexus injuries, thoracic outlet syndrome, and peripheral polyneuropathy or stocking glove, or distal sensorimotor paresthesias. So diabetes is usually the common cause of that particular one. Okay. So in practice, one of the things we wanted to focus in on was the repetitive strain injury. So many patients suffer before the diagnosis is finally made, and you want to consider these when imaging is negative and patients continue to have the same symptoms over and over again. Cluster of injuries that occur from repetitive use of the extremity, including like people that are musicians or are constantly using the computer, or they have poor ergonomics in terms of their body mechanics and the way they position themselves. Some do well with a change in job. Obviously, that's not realistic for everybody. You want to consider putting them on NSAIDs and then time off from work just to give their body a rest. Others that are more severe, they may end up having a permanent disability, loss of function. They may lose their job because they're no longer able to complete it, and they may suffer from chronic nerve pain. So it's not just that it's just sore muscles, it's more complicated process involving nerves, muscles, and fascia. So some of these particular repetitive strain injuries include thoracic outlet syndrome, ulnar and radial nerve disorders, as well as carpal tunnel syndrome. Diagnosis is often made by exclusion and includes x-rays, MRIs, EMGs. Many patients have had big workups looking just specifically for sources of pain. You want to find specialists in your area to consult with and have in terms of referring your patients to people like occupational health doctors and physical therapists that understand and focus on pain management. There's a really good book on this particular subject called Dr. Pasquarelli's Complete Guide to Repetitive Strain Injury. That's really goes further into this particular subject. So in terms of structures in the thoracic outlet and nerve innervation into the arm, these are the anatomical structures we just wanted to point out. Here we have our brachial plexus, and it's just good for you to know anatomically where you're looking at this. Okay, so in terms of ergonomics and occupational health, this is about appropriate posture and positioning of yourself to prevent injury. So things like adequate illumination, so your eyes aren't squinting and putting a strain on your eyes, screen glare and reflection free. They even make blue light glasses specifically for people who are on the computer a lot. Balanced wrist position, what does that do? It prevents you from getting carpal tunnel syndrome, especially when you're on the computer all day, every day. Adequate lower back support at belt level, super important to prevent any kind of lower lumbar straining and poor posturing and poor core tightening. Other things you want to do is definitely encourage, proper weight, nutrition, and sleep, frequent breaks from the computer, get up, walk around, move around, get water, hydrate. Those are really important in terms of preventing and injury and preventing re-injury. Okay, so common complaints in terms of the neck pain. So we talked about this just previously. Numbness, tingling, and radiation are your typical neck pain characteristic complaints. In terms of your exam, you're looking at range of motion, including flexion, extension, rotation, side bending to determine limitations and the pain producing movements. All right. Sperling's maneuver should be used to assess nerve root compression. And in Sperling's maneuver, you want to watch the patient. You want to have the patient in neck extension. You want to rotate the neck to the affected side. Apply downward pressure on the head and then assess for the patient's complaint of or accentuation of limb pain or paresthesia, which would be a positive finding. You also want to observe for obvious atrophy in the neck. The red flags you need to be very clear on making sure if you see them to follow up with is you want to be sure that the C-spine is clear before performing any range of motion. You want to point tender to midline palpation of the spine over vertebrae should trigger an X-ray of C-spine. And then you want to make sure you're assessing if there's any fever, loss of function, erythema, systemic symptoms with the neck pain. So cervical spondylosis is a blanket term for a group of chronic degenerative processes that affect the vertebrae and facet joints and cause pain, stiffness, and disability. Cervical muscle sprain and strain is the most common cause, which are mechanical disorders of the cervical spine. We have whiplash, which happens a lot with motor vehicle collisions, and that's when you have a hyperextension of the neck. Pain following a motor vehicle crash or collision, we need to evaluate for neurologic dysfunction, and you want to get an X-ray to rule out fractures and look for the loss of curve. So this is what you would see in an X-ray with neck sprain and whiplash injuries. You want to look for the loss of the natural curve. So on the left, you see mostly normal, which has the smooth curve, versus you have like a flattened curve on the right, which you see that sharp misalignment. And that's like 15 years after the whiplash. So this is just, when you have that loss of the natural curve, it's because of the spasms that the neck muscles are constantly in because of the pulling on the spine. It just causes over time a degeneration of the spine. So it really is a terrible thing. You really want to make sure you give a lot of support to these patients and really work with them on pain management, not only from a pharmacological standpoint, but also you want to talk about things that will help just from a holistic standpoint, whether it's ice or heat or oils, anything of that nature. So physical exam for neck-related presentations. Obviously, we're going to palpate along the muscles and vertebrae in the middle of the spine for any tenderness, muscle spasms, lymphadenopathy. We're going to be looking at our nodes, look for any enlarged nodes, especially if there's any infection or malignancy that we want to make sure we're ruling out. Midline spine tenderness may indicate a fracture of the C-spine. So you want to collar the patient and get films, like put a soft collar on them and get films of the spine. You want to evaluate the vascular structures in the thyroid. We want to do a neurovascular assessment of the extremities to assess for any sensation or loss of sensation. We want to assess muscle strength in our biceps, triceps, and hand grips. We want to do sensation testing. Any abnormalities in sensation of any dermatome may indicate a C-spine disorder or injury. We want to check our deep tendon reflexes. An altered DTR could indicate cervical nerve root compression, function, dislocations, fractures, and ligament tears. In practice, in terms of torticollis. So what is that? It's basically wry neck or stiff neck. Patient often wakes up with stiffness and spasms and pain. In infants, it's usually congenital. In adults, it's often an overuse, or it's often because of overuse of the joint of the neck. It's this position they were sleeping in or their poor ergonomics. Differential diagnoses you want to consider are dystonia. Ascertain if they have any fever or any indication of meningitis. You want to ask if they've taken any medications related to any of those particular side effects. It can be very self-limiting. You want to consider NSAIDs, a muscle relaxer, heat, and gentle exercise or physical therapy. Okay. In terms of our back, different things you're looking at or seeing presented to you clinically would be your herniated lumbar disc. Usually the most common location is L4 to L5 or L5 to S1. Lumbar spinal stenosis, which is a subsequent compression of the nerve roots. Cauda equina syndrome. This is not very common, but it is a surgical emergency. This is a continuation of the spinal cord below the first lumbar level in the adult. So if you do see this, you need to call 911. Vertebral fracture, which is most commonly associated with osteoporosis. So here's your differentials in terms of low back pain. This is a great little graph just to give you a good summary. So we have our spondylolisthesis, which is usually in around the age of 20. Then we have muscle strain, which is 20 to 40, scoliosis, herniated nucleus pulposus, osteoarthritis, and then spinal stenosis. And here it even tells you what you'll see in terms of diagnostics with x-rays, if these will come positive or negative. So like a muscle strain, you're not going to see in an x-ray. Okay, radiculopathy, which describes a range of symptoms that occur due to compression of a nerve root in the spinal column. It may be cervical, it may be thoracic or lumbar, which radiculopathy can cause herniation, tumor, narrowing of canal, or actually these are the causes of radiculopathy. So the pain that is associated, or the symptoms associated with radiculopathy include pain with radiation, weakness, numbness, and paresthesia. So you'll start to see these patients complaining of numbness and paresthesia, just like crawling down their particular affected joint. Early exam findings are delayed deep tendon reflexes. Later findings may include muscle strength weakness, loss of function, and foot drop. So whenever you see a foot drop, think radiculopathy is probably listed in one of their diagnoses. Tests such as the Sperling test assess for cervical radiculopathy, which may cause the FNP to consider a cervical disc herniation. It is important to assess for radiculopathy to determine if the nerve is being compressed, which may suggest herniation, tumor, or narrowing of the canal. Okay, so back pain is one of the second most common reasons after upper respiratory infections to see a provider in primary care. So common causes of lower back pain, again, are the lumbar strain and sprains, nerve impingement, nerve compression, radiculopathy, and fractures. The most common cause, though, is muscle strain. 90% of lower back pain will resolve in 1 year. It's very subjective. You want to listen to your HPI. Is this new, acute, or slowly progressive? Was there a mechanism of injury? Like, how did this happen? These are the things you want to find out. In your exam, you want to, again, visualize, palpate the areas of concern. You want to do a musculoskeletal exam, range of motion, deep tendon reflexes, neurological sensation, perform special exams like the straight leg raises and heel toe walking. Assessing for signs of nerve involvement to help determine the injury. Is this a strain or sprain or a herniated disc? We want to look at our treatment, which would include NSAIDs, a muscle relaxer. Physical therapy is the cornerstone of most back pain treatment. You don't usually do imaging right away unless there is a loss of function, if there was any kind of trauma like an accident, if the patient is high risk for fracture or narrowing or infections. In terms of herniated discs, the pain often radiates. You may see paresthesias and extremity muscle weakness. Lumbar herniations are more common. You want to assess for changes in the bowel or bladder. Are they newly incontinent? This is a big, big deal. If they are newly incontinent, we are in trouble. The DTRs may be slow, impaired sensate on exam, and unable to walk heel toe. They also usually have a positive straight leg raise. You may try physical therapy, NSAIDs, muscle relaxants, or other pain meds. This patient most likely will require an MRI, and you're going to need to refer them for epidurals, possibly surgery and an laminectomy if the pain is not alleviated with anything else. So etiologies of back pain. So let's talk about our emergency, Cauda equina syndrome. That's an emergency. Like I said just before, if the patient has a sudden new onset incontinence with or without paraplegia, that is an emergency. We call that Cauda equina syndrome. It's a scary thing. It is an emergency that needs emergency surgery. A dissecting aortic aneurysm Can it present with sudden onset of
It's
severe
12
low back
o'clock.
pain in older adults? Pain not relieved with rest, pallor, diaphoresis, and confusion may be present. Possible asymmetrical pulses and blood pressure in the extremities. This is an emergency as well, okay? All other etiologies of back pain could include gallstones, gynecological disorders, prostatitis, pyelonephritis, infection, musculoskeletal strain, spinal fracture, tumor, sciatica, spinal stenosis, spondylolisthesis. And then, of course, a herniated disc is often preceded by years of recurrent episodes of localized back pain. The leg pain usually overshadows the back pain. It's usually radiating. And it's really important that you become familiar with each of these etiologies and how to differentiate them. Go back to that chart because these are the most common things you're going to really see in primary care. Physical exams and diagnostics. So here are just a review of the different tests we were talking about prior that you will be incorporating into your exams that's specific to musculoskeletal. Here we're looking at the straight leg test, which assesses tension of L5 and S1 nerve root. If the straight leg raise test is positive, if pain in the sciatic distribution is reproduced between 30 and 70, passive flexion on the straight leg. Dorsiflexion of the foot also exacerbates the pain. So again, when it comes to the back, your exam includes visualizing and palpating the areas of concern, range of motion, deep tendon reflexes, neurological and sensation exams. Various special exams include the straight leg test, straight leg raise, heel toe walking. Diagnostics depend on what you suspect the etiology is, but it also could include CBC, urinalysis, your ESR and CRP if infectious or inflammatory in etiology. If clearly the injury is related to like a pulled muscle or lifting an object, the blood work is likely not going to be needed. It's just, it's really specific to each situation. Imaging for your back pain, the commonly ordered for lower back pain is an X-ray, an MRI, EMGs. Less commonly ordered would be your CAT scans, ultrasounds, and bone scans. Okay, so the SI joint, sacroiliac or SI joint, like really, really low. It's commonly, it's like your tailbone, basically. It's a very common cause of low back pain or buttock pain. It may be bilateral or unilateral, radiating to the foot or the groin. It's usually greater in women than men, and definitely it happens in pregnancy. I suffered from this tremendously while I was pregnant with my daughter. I was in the chiropractor and I had special orthotics made for my shoes. Both of those things help tremendously. Many special exams, it's best to use several. Palpating the joint is appropriate. It's difficult to palpate it deeply. Patients often point to one spot and it's lateral to the coccyx. Some become chronic. Differential diagnoses, of course, include a herniated disc and other usual causes of lower back pain. Sciatic pain may be caused by herniated disc, spinal stenosis, or compression fractures. Diagnostics usually include an X-ray to rule out disc and other causes of lower back pain, an MRI. Treatment includes NSAIDs. Physical therapy may be very helpful with mobilization techniques, including ice, heat, and possibly SI joint injections. In terms of patient education, you want to definitely avoid having them sit for prolonged periods of time. You want to typically, just reinforce with them that this is typically a chronic condition with flare-ups. So everything they can do to prevent it, or the minute they feel it's starting to come on, they want to deal with it immediately. You want to avoid or caution them on activities or positions that may trigger inflammation, including different sexual positions, pelvic exams, or vigorous lower extremity exercises. Lumbar disc herniation. So differential diagnoses of the lumbar disc herniation could include sprains, strains, or vascular issues. Diagnostics would include plain films, which would show bony abnormalities. It's likely not going to show herniation, but you may see a change in space between the vertebrae. MRIs are usually more valuable in terms of diagnosing a lumbar disc herniation. Most herniations of the lumbar area will improve over time with treatment. 90% usually do, which the treatment includes NSAIDs, muscle relaxers, physical therapy, epidural injections, and of course, you always want to be careful with the use of narcotics. But just keep in mind, back pain is one of the highest types of pain you will see besides cancer pain. So never underestimate the patient's pain just because we are, as a society, are having an opioid crisis. Okay. Doesn't mean that we don't prescribe and treat pain. It just means we're just very conscientious about how we do it and just making sure we're using all avenues to manage the patient's pain. You want to make sure you're having the patient follow up every couple of weeks until the pain has improved, just to make sure they're going in the right direction and they're not re-injuring themselves. We want to avoid heavy lifting, but do keep the patient as mobile as possible. If you get them to stop moving completely, then their joints are going to become stiff and the injury may actually become worse. Some injuries in terms of lumbar disc do require surgical intervention if conservative treatment does not help after about 3 to 6 weeks or any further red flags develop. That's when we want to consider referring for surgical evaluation. If the symptoms continue greater than 3 months or the pain becomes intolerable, or there's a progression of neurological deficits, obviously, again, the patient may require surgery, and this is where we would consider a laminectomy. So the distribution of pain and paresthesia. So this is important to know. I actually do remember on the boards this being a question. It's kind of a random thing, but it's important to know because it will really help you in differentiating your diagnoses as well as doing your physical assessment. So your nerve root, like L3 to L4 versus L4 to L5, and L5 to S1, you will have different findings. So for the L4 nerve root, you're going to see weakness in the anterior tibialis, numbness in the shin, thigh pain, and as an asymmetrical knee reflex. Okay, in the L5 nerve root, you're going to see weakness in the great toe extension, numbness to the top of the foot and first web space, and posterior lateral thigh and calf pain. Excuse me. Excuse me. Thank you. And then in the S1 nerve root, you're going to see weakness in the great toe flexor, inability to sustain tippy toe walking, and numbness in the lateral foot. So you see how the colors differentiate where the nerve affects the extremity. This is a great little diagram to have in your pocket just to make sure you always can differentiate where their symptoms will be and your findings will be associated with. Okay, lumbar spine in terms of patient education. So things you want to be educating the patient on. You want to, again, encourage the physical therapy, the exercise. Remember, this is often the bedrock of therapy. And exercise at minimum, some mobility is crucial to keep the patient as mobile as possible to help prevent disability. Mental health in terms of giving them just encouragement. If the employment is in jeopardy or the patient cannot work and having chronic pain, you want to watch and treat for any sort of depression, encourage them, refer them to outpatient therapists, social workers, anybody who can help get them support at home for their finances and whatever else they may need to apply for. Financial, social, and marital, often back pain can become chronic and impact all areas of life. So you need to take that into consideration and refer as needed. Again, these patients may have sudden inability to do certain things for themselves anymore, whether it's work or physical abilities. So you want to consider, would these patients benefit from home care services, and see if they qualify. In terms of sexual education, you want to just discuss with the patient any concerns. You want to just encourage them to try different sexual positions that work for them and they find comfort in, so they can still, enjoy that part of their life. It will also provide relief for their stress and mental health. So you want to encourage that as long as they can tolerate it. Obviously, you always want to encourage and promote smoking cessation. Remember, smoking is something that causes more inflammation, and the more inflammation any of these patients have, in particular with musculoskeletal injuries, the more pain they are going to experience. And it also affects their circulation, of course. So these are all things to just kind of incorporate into your education so they can really look at smoking at a bigger level than just, it causes lung cancer, and my doctor's bothering me to quit. No, it's a lot bigger than that. In terms of mind-body movement therapies, that has been shown to have positive effects like Tai Chi, acupuncture, chiropractic, as well as turmeric as a supplement, as an anti-inflammatory. All these things are incredibly helpful in medicine, and I would encourage you to encourage your patient to take into consideration all of these different modalities. Lumbar stenosis. So this is narrowing of one or more of the spinal canal with nerve root compression. It's usually older population or congenital and may be triggered by a minor event and gradually worsen. Symptoms include radicular symptoms into the legs, which worsen with walking, standing, muscle weakness. You will see an impaired Romberg and decreased deep tendon reflexes. Pain is often relieved when leaning forward. This can be diagnostic when trying to determine your etiology. So again, if you see a patient with lower back pain coming in and they are saying to you and showing to you that their pain is relieved when they lean forward, you want to consider lumbar stenosis. X-rays, AP and lateral may show the narrowing of the spinal canal. So that might be helpful in diagnostics. NSAIDs, physical therapy, weight loss, and epidural steroid injections are very helpful in managing the symptoms of this. Lumbar stenosis can worsen over time. The pain does interfere with sleep, and you want to watch for the cauda equina, the red flag we talked about before, where the patient suddenly develops new onset incontinence. Remember, that's an emergency red flag. You want to make sure you're watching this patient's gait. If they're having any difficulty standing erect, watch for depression. And again, they may require surgery over time. So vertebral fractures. These, again, you want to look at your HPI. Is it consistent with the level of trauma the patient has sustained? Is this, you want to consider osteoporosis, possible cancer or tumor, or is there any other risk for fracture? Because remember, trauma, osteoporosis, and cancer and tumors put you at risk for fracture. So you want to consider all of these when you're looking at your differentials and diagnostics. The different types of vertebral fractures include burst, compression, and dislocations. Obviously, at the site, it is painful and it's tender when you point at it, or you point tender, as they say. X-rays and MRIs usually reveal the fracture. Other diagnostics may be ordered depending on the suspected etiology. You do want to make a referral to orthopedics or neuro if there are neurological deficits. Treatment would include bed rest, back braces, physical therapy, exercise programs, electrical stimulation. That's actually really helpful for some people. Opioids and other analgesics, lidocaine patch, and back braces. Patient education would include just educating people not to avoid, you want to make sure they avoid bending, stooping, twisting, or lifting. So no bending, twisting, lifting, or stooping, and nothing greater than 10 pounds. I'm going to tell you to tell them more than 5 pounds, because most people underestimate how much weight that actually is. Of course, you want to educate again on smoking cessation and avoid excess alcohol, especially in terms of avoiding throwing off their gait and causing any further injury, like if they fall because they're dizzy from drinking. Weight bearing and muscle strengthening exercise should be encouraged when the healing of the fracture is complete. We want to make sure we don't have any atrophy in that muscle or joint. And we want to make sure we're doing a fall risk assessment and fall prevention strategies and education with both the patient and the caregivers. Fractures on an X-ray may be clearly or not so clearly visible. If they aren't clearly visible, then you want to make sure you do an MRI for follow-up as needed. Okay, so hip pain. In terms of differential diagnoses, we have anterior hip pain. Hip joint disease could include osteoarthritis, neck fracture, septic arthritis, femoral acetabular syndrome, and avascular necrosis. We have neuralgia paresthetica. We have the lateral side. We have greater trochanteric bursitis, external snapping hip, and then in posteriorly, we can consistently see radiculopathy, sacroiliitis, or sacroiliac joint pain, as well as piriformis syndrome. In terms of hips and fractures, things you're looking for in your diagnostics and your assessment, you want to observe for symmetry. Remember, look at the both sides, good and bad. You want to compare the two. You want to do palpation of your bony structures, your muscle groups, your bursa and your SI joint. You want to look at your active range of motion, have the patient do hip flexion and extension, adduction and abduction. Osteoarthritis usually affects the internal rotation and abduction. So just keep that in mind. And then in terms of a fractured hip, external rotation and abduction with the leg length discrepancy would show you that you have a fractured hip. It's due to the muscle spasm and shortening. You want to do all of this while you're observing the patient lying on the table or stretcher and observing from the feet. So you want to assess what the mechanism of injury, just like all of these musculoskeletal injuries, what is your mechanism of injury? Usually with hip fractures, especially in our elderly population, it's related to a fall or trauma. Your higher risk population are your older geriatric patients, including mostly females, especially if they've had any prior history of hip fractures or falls. Any patients who have a history of osteoporosis are sedentary and are on any medications that may put them at higher risk. Symptoms would include pain when standing, especially into the groin on the affected side, and usually they're unable to bear weight. In the exam, you're going to see external rotation and abduction, may see leg length discrepancy. The leg that's fractured is usually shortened because, again, of the spasming and the muscle being shortened. So diagnostics include x-rays of the hip and pelvis. MRIs and CTs will show usually a small hairline fracture. The fracture will determine the type of repair or replacement the patient's going to require. Obviously, we're going to refer to the emergency department or orthopedics for likely an ORIF or a hip replacement. Keep in mind our geriatric population, unfortunately, may have a high mortality rate due to the complications, that occurs in older adults. I always say when a patient, an elderly woman, especially women, but just an elderly patient falls and they break a hip, oh, that's when the end is coming. It's just always never a good sign. You want to look for external rotation and leg length discrepancy in a hip fracture. So you see how in this picture, you see the patient's foot is shortened and externally rotated. That's a perfect example of what it looks like. I've seen it so many times because anytime I find a patient that's fallen, it's pretty consistent what you see. All right, so patient education on hip fractures. You want to make sure that you educate them that they should come from, they should go make sure they follow up with orthopedics after they get their repair. It's important that they avoid crossing their legs to prevent further re-injury. They are going to probably require physical therapy either at a rehab facility or at home. They want to avoid high heels. They want to make sure to be positioning themselves properly at night with pillows in between their knees for sleep and comfort. And if the joint is replaced, obviously they're going to need to follow their orthopedist instructions. So a hip bursitis, the people at highest risk are women 30 to 50 years old. Multiple bursa hip and pelvis is common in trochanteric bursitis. It's usually insidious on onset, and the symptoms you're mostly going to see are the pain at the palpation of the bursa, worse with abduction, stepping, or walking upstairs. And you see where he's pinpointing, that's where you're going to see the point tenderness. You're going to assess the IT band, and tightening of the IT will worsen pain as it runs over that bursa area. X-ray is usually done in terms of diagnostic, mostly to rule out other causes because bursitis doesn't actually show up on the X-ray. Treatment includes NSAID specific physical therapy and exercises, steroid injections, and of course the last resource would be to remove the bursa. Meralgia paresthetica. So people who are highest risk are diabetics, middle age, pregnancy, obesity, tight clothes, tumor, anything causing compression of this nerve. Symptoms are just pain with walking, standing, usually improve with sitting. Pain distribution is the anterior thigh. Diagnostics are usually not needed. Treatment depends on the cause. Usually you want to just promote weight loss, less tight clothing. A lot of women wear those tight jeans that you want to promote, like just to loosen their clothes. And of course you want to promote medication to relieve nerve pain, including nerve blocks if it's necessary. Usually it resolves, but sometimes the numbness does persist. Okay, so avascular necrosis. This is the lack of blood supply will cause necrosis. It usually occurs in areas of the body more prone to lack of blood supply, like the wrists and the hip. So who's at risk? Usually it's complications of hip trauma, alcoholism, or chronic prednisone use, vascular insufficiency, Symptoms would be abrupt hip pain, progressive with intermittent episodes. The pain usually worsens with motion and activity at night. It's a limp, limited abduction, and internal rotation is what you're seeing on exam. And your diagnostics are likely going to be the x-ray is done first, where you may or may not see. So the MRI is the gold standard test for avascular necrosis. Just keep that in the back of your head. Again, avascular necrosis, your MRI is your gold standard test. That's going to be probably a question on your boards. Okay, coccyx injury, usually the mechanism is a slip and fall right onto the buttock or lower back. Trauma to the area, also childbirth and repetitive stress like bicycling or spin bikes can cause coccyx injuries. Usually it's just a pain at the coccyx with ecchymosis, tender to palpation, pain with sitting, bowel movements, and sexual activities. Exam can include specific rectal exam to assess the coccyx, but you may not always see this done in practice. If you do suspect a fracture to the coccyx, you can do an x-ray. If no trauma and suspecting coccygodynia, you may want to consider an MRI to rule out a neurologic etiology. You do want to do the x-ray to make sure it's not displaced, and you do want to refer to ortho as if the pain continues. Treatment will include the NSAIDs, a pain medication, stool softener, a donut pillow for sitting that's got that cutout so it relieves the pressure from the coccyx. Injections around the area. It may take several weeks to notice a significant improvement. That's a really sensitive area, so it does take a while to heal. Coccyx pain without trauma definitely needs further evaluation. Okay, knee. So acute pain in your differential diagnostics, you want to consider in acute pain of the knee, consider fractures, meniscal injuries, ligamentous injuries, musculotendinous strains, extensor mechanism injuries, or contusions. So consider your mechanism of injury. Did we have a hard blow or a fall? Then you want to consider a fractured patella or femur tibia. Did we have a twist injury with a planted foot? That's when you want to consider a meniscus injury. Was there a oppo or a locking? A pop, I think that means, was there a pop or a locking? Was there a blow to the knee, like a ligamentous injury, ACL, PCL, LCL, or MCL? These may be incomplete because the patient may still have some use, but that doesn't mean that the injury isn't there. Weight bearing, can the patient bear weight, stand? Okay, treatment. Are you using guidelines such as the Ottawa knee and ankle rules? So remember, we have these rules, these evidence-based practice standardization rules in place for a reason. Okay, this will guide your practice so you're doing best practice. So HPI, what was the mechanism of injury? Was there popping, clicking, catching, or giving out? You're going to use your exam. You're going to assess the ligaments, your drawer signs, your valgus, your varus stress, patella, assess for bulge, battlement, range of motion, crepitus function, and weight bearing. If it's significant injury and the patient is very guarded and unable to perform the exam adequately, that's when we definitely want to consider an x-ray. And then if we need to, an MRI. MRI is more likely used for the meniscus injuries and ligament tears. Again, treatment is pretty consistent. Usually you're going to start with an NSAID, consider if the injury requires more pain relief, immobilize, address weight bearing, possible use of crutches. Again, make sure you're educating on how to use the crutches and refer to ortho as needed, and assess to make sure that this is not putting the patient at high risk for falls. Knee. So chronic insidious pain differentials can include arthritis, tumors, sepsis, and overuse syndromes such as bursitis and tendonitis. It causes pain, aching, and limitation of range of motion. You want to consider the HPI, the PMH, the obese, risk factors, other immune diseases, and other joint issues. Diagnostics include blood work, which would include your CBC, your ESR, your CRP, your rheumatoid factor, ANA, and other autoimmune panels or tests. Your x-rays are going to be used to determine the severity of damage to the joint, and if there's any erosion, arthritis, or degenerative changes. Again, your treatment is dependent on the disease process and etiology. Okay, so here's your Ottawa knee rules. So again, simple decision tool, well known, especially for the use with an ankle injuries. This is helpful for the provider to use to know when to get an x-ray. It's evidence-based, so this will justify you ordering your x-rays, especially if insurance companies want to turn around and say that they're not going to pay for it for whatever reason. You can use this as a guideline and make sure you're documenting that where that you use these knee rules. And in this particular knee rule, you're looking at the knee x-ray indications after an acute knee injury. If it's a patient of 55 years or older, is there tenderness at the head of the fibula? Is an isolated tenderness of the patella? Is there an inability to flex the knee to 90 degrees? And is there an inability to bear weight? Again, these are all indications for an x-ray. Ankle and foot pain. Differential diagnoses include sprain, bunions, neuromas, pes planus, stress fractures, hammer toe deformity, arthritis, Achilles tendonitis, plantar fasciitis, bursitis, heel spurs, corns, and calluses. Lots of different things to look at. So just keep in mind that there are plenty of different things to consider when you are making your diagnoses. Sprained ankle is very common in musculoskeletal world. So just keep that in mind. The major differential is a fracture. So it's either a sprained ankle or a fracture. Those are the things you want to rule out. You may have avulsion fractures with rollover injuries because the sprain pulls a little chip off of the bone. They do grade it again, 1, 2, 3. Use the rules to x-ray. You have a low threshold to x-ray in older adults because of cancer, osteoporosis, etc. You want to consider commonly injured ligaments like the ATFL and the CFL. And of course, your treatment is going to include the RICE, rest, ice, compression, and elevation. Boots or ankle support. You want to address the weight bearing with crutch walking, a walker, or a cane. You want to consider NSAIDs, physical therapy, and again, refer to ortho if surgery is necessary. Inform the patient that recovery times vary. Extensive grade 3 sprains may take months before full recovery and involve, plenty of physical therapy and home exercises to get back to our full use. So here are the sprained ankle mechanisms of injury, the pretty common ones. Ankle sprains occur when the foot rolls too far inward and common in someone with high heels. And here it shows you on the right-hand side, the ATFL and the CFL. Okay, so when using your Ottawa ankle rules, you want to apply them accurately by palpating the entire distal 6 centimeters of the tibia and fibula, not neglecting the importance of medial malleolar tenderness, and using the rules only on those patients over the age of 18 who are not pregnant. Make sure you give your patients written instructions and encourage follow-up in 5 to 7 days if pain and walking ability have not improved. So here's a really good view at lateral and medial of the ankle to give you your landmarks of what you're looking at. So these are your malleolar zones, and this is where you want to be palpating for any pain, because the bone tenderness in these particular areas are going to be what indicate whether or not you're going to order the x-ray or not. Okay, interpreting the rules. So an ankle x-ray is only required if there is any pain in the malleolar zone. So this gives you the instructions again on how you're palpating that particular zone. And a foot x-ray series is indicated if there's any pain in the midfoot zone and any one of the following. So bone tenderness at the base of the 5th metatarsal or at the navicular bone, or an inability to bear weight. Okay, so ankle fractures occur from the same motion as sprains, twisting and rolling over. Frequently, we'll see the medial malleolar or lateral malleolar. A lot of the times, you'll see bimalleolar or POTS fractures in soccer players or others when the ankle rolls back and forth both ways. And that's usually what happens when they're playing as rough as they get in soccer. Trimalleolar is if both malleoli and posterior margin of the distal fibula. And as with all fractures, you want to rule out if it's displaced. Does it need reduction or an ORIF? If it does, you're going to immobilize and make an orthopedic referral. Many are not as obvious on an x-ray, so you may need extra views. Okay, Achilles tendon ruptures. Okay, very painful, and it causes an inability to walk normally. It's a push-off injury, so these are the people who are at higher risk, or like basketball players, because they're jumping for a shot. And usually it occurs spontaneous from relatively minor trauma. It can be a side effect of fluoroquinolones or steroids. So just keep that in mind. Achilles tendon can be a side effect of that. Usually your physical exam is going to show swelling, tenderness, and bruising over the site of the rupture. You want to perform the Thompson's test specifically for Achilles tendon, where you have the patient lie on their belly or prone and you squeeze the calf. And the test is positive if squeezing the calf does not produce a plantar flexion of the ankle, which would indicate a rupture of the tendon. Treatment includes surgical repair or immobilization with a cast with the foot plantar flexed. You may need an X-ray or an MRI. Again, the treatment depends on the extent of the rupture. You're likely going to need to splint, use crutches and NSAIDs. These patients have a lot of pain. Putting any weight on their Achilles really is not even an option. So you're definitely going to likely need to splint and give them crutches. Again, here is a review of your landmarks in the foot and ankle. Foot fractures. So calcaneus, navicular, metatarsal. Remember, you have a lot of bones in that foot. You have, 206 bones in the body, and half of them are in your feet. So there is a lot of possibility for foot fractures. We see it with trauma, we see it with injuries, and a lot of athletes. Again, your history needs to include the mechanism of injury. You want to assess for swelling, pain, you want to note where your point tender on the joint, and can they bear weight? Check for pulses. You want to do a neurovascular exam, look at their sensation and their range of motion. Again, x-rays may need specific views. If you're not sure about the injury and it's unclear, you want to maybe get an MRI, refer to ortho for splinting. Again, treatment may include surgery, physical therapy, crutch walking, NSAIDs, pain medication, and rice. Common foot disorders include neuromas and plantar fasciitis. Remember, with plantar fasciitis, you're usually worse with the first step in the morning and then late in the evening. A neuroma is a benign growth of nerve tissues, usually between the third and fourth toe. These patients with the neuroma usually complain about pain when they're walking, where it feels like they have a stone in their shoe with stinging or burning. See, there it is, a picture of Morton's neuroma, how it's in between. It feels like a little stone in there. And then the plantar fasciitis is more in the arch. Okay, so in practice with fractured toes, usually it's a crush injury or a stubbing. You want to do an x-ray if it's not open, displaced, or it's otherwise a stable fracture. You can do a buddy tape and use a rigid sole shoe for a couple of weeks until the tape is no longer needed. Again, NSAIDs, ice, rest, elevation. You want to watch for nail bed injuries, which would suggest if you need the x-ray. In practice, you're going to see taping. This is a newer practice, to be quite honest. I hadn't seen it that much until recently. Most of the time in the rehab facilities I go into, it's the occupational therapists who are doing the taping. It's a newer method of treatment and prevention for sports injuries. It actually has an older kind of treatment. It's actually an older treatment, but I hadn't seen it done very frequently until recently. It's good for plantar fasciitis. It's really good for helping with swelling and sprains and just giving the joint a little relief, because it just kind of gives it some support when you use the tape. Okay, so the shoulder, you want to review your anatomy of the shoulder. We have our clavicle, scapula, and humerus. Okay, and the four joints, sternovicular, AC, glenohumeral, and thoracoscapular. It's a ball and socket suspension joint, which maximizes its mobility. There's two common complaints with shoulder. Usually it's pain and or instability. So the symptoms usually are a decrease in motion or power or function of the shoulder, which with accompanied complaints of pain or instability. Common conditions include acute injuries, fractures, dislocations, acute tendon rupture, chronic or repetitive injuries, and degenerative or inflammatory or idiopathic conditions. Most shoulder disorders can be diagnosed with careful history, clinical exam, and plain radiographs. You will see many MRIs ordered, usually plain film first. So usually you want to do the plain film first and then go forward depending on the symptoms. Again, very similar to all the other musculoskeletal pinpoint exams in that you're inspecting colors, symmetry, edema, and swelling. You're palpating for tender areas. You want to know any sounds, any deformities, any temperature changes to the area. Inspect anteriorly and posteriorly. You want to look at the normal shoulder versus the abnormal shoulder. to get a good comparison of the differential in the way they look or present. You want to look at both active and passive range of motion exercises, which you should be testing while comparing the painful shoulder to the unaffected side. You want to really look at that range of motion and determine discrepancy between active and passive motion. We're looking at abduction, adduction, internal and external rotation. Disuse can cause passive range of motion loss, so just keep that in mind. And special tests to assess range of motion include the Apley test. So the Apley scratch test evaluates the range of motion, and it's basically, can the patient lift their hand over their shoulder and reach back and touch it, both from top and then underneath. So in common things you'll see in terms of shoulder issues in practice is the AC separation, all right? And then frozen shoulder is also common. Rotator cuff injuries are also common. Usually athletes usually come in with this because of chronic wear and tear and overuse. It does become degenerative. Narrowing with age causes friction on the cuff, causing impingement, and tears can happen anywhere in the cuff. About 50% of people over the age of 60 have partial tears. So rotator cuff injury, tendinitis can be caused by overuse. Usually we're seeing with tears, the pain is worse at night. You'll see tired, weakness. The patient will report catching or clicking sometimes. And of course, there's limitation and pain on abduction. Diagnosis begins with an X-ray, and then you want to refer to ortho depending on the extent of the injury. So dislocations of the shoulder, 95% of shoulders dislocate anteriorly. Just keep in mind, posterior dislocations are rare. The mechanism of injury is usually the patient is falling and grabs for something to break the fall, and the arm gets forced into abduction. You'll see a visual deformity, usually a downward sag of the shoulder. Diagnostics should include a 3-view X-ray, A&P lateral and axillary. The arm needs to be relocated into the joint. So you want to talk about pain, that's painful. Treatment includes, orthopedics, obviously with an experienced provider who can really have quick access to repeated X-rays and meds. Usually you're going to prescribe a pain medication, muscle relaxer, inject the joint with lidocaine as needed. And you want to make sure you repeat the X-ray after you put the joint back you relocate the joint to make sure that you have proper alignment. This patient will be high risk for repeated dislocations. Just keep that in mind. So here's a comparison of a normal film to an anterior dislocation. So you can see that the shoulder is obviously not in the right place. The ball of the humerus has slipped right out of that socket. So it's a good comparison in those. Okay, so bursitis, just general guidance. You want to review the location for specifics with diagnosis. Example, is it in the hip, the knee, the shoulder, the elbow, etc. Any joint with bursa sacs can experience bursitis, so it can pretty much happen in all your joints. It's usually in the shoulder because it's caused by overuse. Typically, the patient is experiencing aching, which limits the range of motion. Be alert to the possibility of infection as a differential. Review the use of joint with the patient, overuse, new activity, etc. The first line of treatment varies depending on where the bursa is. You're either going to do NSAIDs, injections, or aspirations. Patients have usually tried the NSAIDs prior to even presenting to you. Intrabursal corticoid injections, often given, usually are quite effective, but there is soreness after the injection. Okay, so in practice, you may see a rupture, which is a Popeye deformity. It is possible to rupture tendons and muscles. This photo is an example of a biceps rupture. Be aware of visible deformities in muscles. Common mechanisms of injury that occurs with ruptures usually are from patients lifting heavy objects. They may complain of loss of function, may or may not have pain, and they definitely probably have heard a popping sound. So you want to refer that particular patient. Getting into common musculoskeletal chief complaints, things we're going to see a lot are elbow pain. Most commonly seen complaint is the lateral epicondylitis of the humerus, which is also known as tennis elbow. In practice, you're going to see both tennis elbow and also golfer's elbow or medial epicondylitis. You also may see fractures, dislocations, arthritis, and bursitis. So in practice, in elbow conditions, when we're getting into tennis elbow, it's just an accumulation of micro tears with inflammation. Again, NSAIDs, self-limiting, ice, steroid injections, physical therapy, activity modification. Sometimes you want to prescribe a counter tension band to be worn with activity. Sometimes it relieves the stress from the inflamed tendon. If it lasts greater than 6 months, that's when you want to refer to an ortho or a hand surgeon because it may be indicated. A golfer's elbow is also micro tears and inflammation at the origin of the muscles that flex your wrist downward. Classic findings are point tender medial epicondyle and weak hand grip. It's similar to the lateral epicondylitis. Okay, so your elbow bursitis. So the bursitis of the olecranon, you're going to feel pain and swelling in the posterior aspect of the elbow. It usually occurs with forced extension on the elbow joint, like leaning with the elbows on the table. Range of motion is usually normal. You need to rule out septic bursitis with fever, redness, and warmth at the site. Synovial fluid aspiration can provide evidence of infection. Obviously, diagnostics like an X-ray can rule out a bony infection and fractures. We only want to treat this if it is actually a true cellulitis. Again, more reviews of the hand and wrist anatomy. This is really important for you to be aware of because you want to make sure you're able to document appropriately the location of where the injury and the symptoms are presenting. So you want to make sure you're using the right terminology. Okay, so hand pearls. So things that just to make sure you're aware of. So mechanism of injury, of course, again, is really important with the hands. So consider the FOOSH injuries. FOOSH acronym for fall on outstretched hand are known patterns of injury that occur with this mechanism. So there's multiple do not miss hand and wrist fractures with high morbidity if you miss them. So have a low threshold to x-ray hands if you suspect any possible bony or ligamentous injury. You want to make sure also when it comes to the hand that you're documenting the hand dominance. Is the patient right or left-handed? You want to talk about ergonomics. Excessive gaming, video games, keyboarding can cause significant problems on the hand, fingers, and wrists. What does the patient do for work, which is often a clue to the mechanism of injury? Okay, are they in IT? Do they work on the computers all day? These are clues. Don't forget cervical spine innervates into the hand. Injury may actually be coming from the neck. Consider it in your differentials if appropriate. More pearls for hand injuries. Examine and document the anatomic snuff box, okay? So it may be workman's comp issues. Be sure your documentation is thorough. Encourage immediate removal of rings with liquid dish soap, lubricant, special technique, or ring clutter will be required. Your injury, again, the patient's injury may impact their ability to work or write and perform ADLs. Hence, it can be a litigious area, meaning, you're going to have to make sure you're documenting everything appropriately so this patient can get appropriate, time off or paid time off or disability as indicated. You want to consider referring the patient or having them follow up with a hand specialist. Orthopods with subspecialty see injuries from fingers to elbow, and physical therapists specializing specifically in the hands. You want to look at lacerations from bites, traumatic injuries. They may scar, may leave the patient with reduced function, and as well as leave them at risk for arthritis in the joint later on. So be sure to inform the patient of these risks. Okay, so in terms of assessing wrist and hand pain, these are the differential tests: your Allen's test, Phelan's test, Tunnell's sign, and Finkelstein's test. And things you're asking: is there any repetitive use? What is our mechanism of injury? You want to assess strength in the wrist, the grips, and the fingers, and you want to do a neurovascular exam. Okay, carpal tunnel. This is an extremely common wrist condition considered. It's usually considered when there's an overuse or repetitive strain injury on the wrist with increased pressure on the median nerve. These patients that are high risk are patients with poor ergonomics with their work, pregnancy, thyroid, arthritis, ages 45 to 60. Carpal tunnel is also associated with low aerobic exercise and a higher BMI. Symptoms are usually numbness and tingling, most often in the morning, and it may be the whole hand or the palmar surface with the fifth digit. The patient's gonna be complaining of pain, an increase in weakness, dropping objects. Differential diagnoses could include cervical spine disease, Lyme's, MS, or thoracic outlet syndrome. Diagnostics should include X-rays as a baseline, unless you're considering Lyme's or diabetes as a suspected diagnoses. EMG and nerve conduction studies offer more of a definitive diagnostic capability. And if the patient is a surgical candidate, they may require an MRI. The pre-treatment is wear wrist splints. Most often the ones over the counter are fine. You can get some custom made if you need to, but you want to wear them at night for at least 3 to 4 weeks to help relieve the wrist. And you may want to refer the patient for steroid injections and physical therapy. You know, there's less benefit obviously observed from NSAIDs, stop repetitive use, may need an ergonomic assessment at work, change in job functions. I mean, those are all great, but that may or may not make it any better. Okay, so the carpal tunnel, when it comes to the exam, it's recommended to not make the diagnosis on a single test. You want to use several techniques, EMGs, and overall presentation. You would expect to see the symptoms along the median nerve distribution, or it may include the whole hand, but definitely around the pinky and fourth ring finger. You're going to see abduction weakness. You're going to check for the flick sign, the Phelan sign, and the Tinel sign. Those should all be positive. In practice, okay, when it comes to a wrist fracture, you want to listen for the mechanism of injury. If the patient reports a fall in the outstretched hand, you want to look for the distal radius, aka the Colles fracture. Symptoms would include positive or negative visible deformity, may or may not have that. They are going to have swelling, pain, and limited range of motion. Your diagnostics include an X-ray. You're definitely going to refer for splinting and casting, and they may need surgery. We're going to encourage price, NSAIDs, pain meds, and eventual physical therapy. Okay, ganglion cysts. This is the most common lump you will see in hand and wrist area. Okay, it's usually you're going to see it in the ages of 14 to 40. You're going to see it a lot in gymnasts with increased wrist stress. The exact etiology is unknown, but we do know it is a fluid-filled cyst that arises from the joint with the tissue surrounding the joint. It should be able to transilluminate. It may or may not be painful. X-rays are sometimes inconclusive, but it may help to rule out a bone tumor. MRIs are more helpful if needed at all. You just want to watch and wait. It may disappear. Limit the excess use of the joint. You want to aspirate the fluid out if it's painful or limiting movement. And you may need surgery, but hopefully it'll go away on its own. Okay, anatomic snuff box and navicular fracture. Okay, so multiple structures in a small area. So there's a lot of structures. There's multiple structures in this small area of the wrist. So when you put the thumb out in the hitchhiking position, located in the hollow area just below the base of the thumb, you want to palpate where you're looking for tenderness to suggest the fracture. Fractures and injuries are easily missed here, even on an X-ray. So you want to make sure you're examining and documenting that appropriately. You may need additional views on an X-ray to rule it out. And just keep in mind, this is a poor area for healing. It's prone to avascular necrosis. So, okay, boxer's fracture. That's usually a displace of the fifth metatarsal. Punching injuries are the most common mechanism of injury in this particular one. Usually it's pain and swelling over the area. And the story is sometimes inconsistent with the injury because nobody wants to talk about the fight that they got into. It's typically splinted and they may need surgery depending on the fracture. You're going to treat with NSAIDs and pain meds. Flexor tendon tenosynovitis. So this is often due to bacteria or injury, overuse, inflammatory conditions. You really need to determine the cause here. You will see canaval signs, which is indicative of disease, which is not always going to be present. But when you do see pain with passive flexion, that's when you know it is. You may also see or have reported the puncture wound and injury. It is considered an orthopedic injury, so emergency. So you want to move quickly because infection can spread quickly. This is differential diagnosis. You may want to consider gonorrhea. Diagnostics would include a CBC and ESR, cultures, and an X-rays. Again, if it's determined to be infectious, you want to make sure you get orthopedics involved on an emergency level, collaborate with them, either send them to the emergency room or have surgical intervention ready. Okay, so here's the pathophysiology of the flexor tenosynovitis. So here's your hand. Under the skin in your palm, there are tendons that bend your fingers. Okay, we know this. These tendons are surrounded by a sheath, which is in blue. The sheath keeps a thin layer of fluid around the tendon so it glides smoothly. The problem is a small splinter can introduce bacteria into this sheath, and the bacteria can easily travel down the finger into the hand, causing a large infection. Interesting. Okay. So you need to move quickly, obviously, because that infection can spread quickly. It is determined, well, like we said, we want to just make sure that we get the orthopedic emergency involved quickly through the ER if necessary. Okay, here is a de Quervain's tenosynovitis. It's a lot of swelling and inflammation, usually again from repetitive movement, like on a keyboard. Usually the pain is at the base of the thumb with gripping and weakness. Diagnostics should include an X-ray to rule out other conditions. And you will have a positive Finkelstein and Eichhoff exam. Usually requires rest, splint, possibly surgery. You want to avoid repetitive use. You want to consider injections and physical therapy. Okay, so trigger finger. Now remember, just keep in mind, this is caused by inflammation, trauma, diabetes, rheumatoid, or other unknown etiology. But there are 3 stages of severity. In stage 1, the hand is tender at the site of the inflamed pullean tendon. At stage 2, the affected finger will catch or click when bending it, but it does not get stuck. And then stage 3, which is the most severe stage, the finger will get stuck in a bent position like you're pulling a trigger. The tendon is too swollen and it just gets stuck in that pulley position. Management includes injection into the tendon sheath, modifying activity, and surgery if needed. Then we have our mallet finger, which is a Voll's bone chip. It usually occurs when the tendon snaps off and there's a tearing of a small piece of bone away with it. Usually it's a hit tip of the finger directly with like a basketball or something. Exam is pain, swelling, and droop in the finger. X-rays will show a fracture. You should splint it immediately and refer to the hand tip. Typically, you're going to refer to the hand specialist. You want that hand splinted for about 6 to 10 weeks. And then if it's necessary, then we refer to our hand specialist. Okay, so in practice, when it comes to work notes and workman's comp for your patients, you will be in charge of providing those for your patients. So keep in mind, you want to make sure that they are appropriately written and documented carefully. Because a lot of these orthopedic and musculoskeletal injuries do require a time away from work. So it's balance of providing reasonable time off for the patient with a goal of getting the patient back to work. Research suggests that the longer a patient is out of work, the less chance they will return. You want to consider providing documentation to support your patient's time off from work. Can the patient return to work with limitations or an alteration in work responsibilities or reasonable accommodations? You want to have a real conversation with your patient. Some employers require documentation after a specific amount of time away from work. Usually it's more than 3 days they need a doctor's note. The patient's employer may ask them to complete work-related documents, which you will need to assist in filling out. And of course, if the injury is workman's comp, you want to be expected to be contacted from the agency for regular follow-up reports. Okay, so in summary, applications to practice. So for most musculoskeletal issues, you want to listen for clues in your HPI. Was there a mechanism of injury, acute or chronic? Any other symptoms that would indicate infection, metastasis, or an inflammatory condition? Most musculoskeletal injuries get a referral to orthopedics either for definitive treatment or for follow-up. Are there any visible deformities, loss of function, or impaired range of motion? Remember, that is documented whether they have it or they don't have it. Always assess for and document neurovascular compromise and muscle weakness. And keep in mind, there are hundreds of special exam techniques for this system. Learn 1 to 2 for each area, like the back, the shoulder, the knee, and then build upon those depending on how you need it. All right, guys, that's it for today. Thanks so much. I hope this was a really helpful video. I hope you have a great week, and I will see you next week. Thank you.